Good morning. Thank you for asking me to present on simultaneous surgeries and gastric bypass. These are my disclosures. This is me presenting last year in Baltimore, so just picture me out there on the podium. I'm really here in beautiful, sunny Portland, Oregon. This was a recent sunrise. What I'm going to focus on are what I'm calling the big four in simultaneous surgery: hiatal hernia, ventral hernia, cholecystectomy, and liver biopsy, which I'm going to spend the most time on. Here's an upper GI of a paraesophageal hernia preoperatively. This was one that I found incidentally years ago prior to doing routine endoscopy before surgery. And the procedure here was, of course, to dissect out and reduce the entire sac so the GE junctions resting comfortably in the abdomen without any tension. Then go ahead and do the gastric bypass. And finally, close the hernia defect. This is what this one looked like when the bypass and hiatal hernia were completely repaired. We're fortunate in bariatric surgery, because of all of our efforts in quality, that we have the MBSA-equipped database to mine, which is a very large database. This is a study out of Edmonton, Alberta, Canada, looking at concurrent paraesophageal hernia repair with bariatric surgery. They looked at the 2015-2016 database. At that time, there were 791 accredited centers, and over 42,000 underwent paraesophageal hernia repair, whereas 222,000 didn't. And so the paraesophageal hernias were done as 16% of that cohort. They were able to make 42,000 propensity-matched pairs, controlling for age, gender, and comorbidity. And they found there was no difference in 30-day major complications, which was 3.5 and 3.4%. And they therefore concluded that concurrent paraesophageal hernia repair is safe. Moving on to incarcerated ventral hernias. The MBSA-equipped database has also been used to look at that. They're done less frequently, 1.1%. Propensity-matched cohort analysis was also done, controlling for sleeve or bypass with and without ventral hernia repair. And they found that ventral hernia repair had more major complications. In the gastric bypass group was 9.3 versus 5.7%. So this should be approached cautiously or only if absolutely necessary. My approach is to do this and then come back and do the bariatric surgery if it's a large hernia in the way. Cholecystectomies. Much longer history, as these were more frequently done concurrently in the open bariatric surgery era. And it's historically been trending down. It was down to 26% in 2001 and 3.7% in 2008. And there's some significant considerations with cholecystectomy, post-gastric bypass, or concurrently with gastric bypass. And that, of course, you're unable to do a normal per-oral ERCP following a gastric bypass. For the patient, it's one operation versus two. And for the surgeon, of course, if it's a large liver, it will shrink postoperatively and make the cholecystectomy much simpler. Using the MBSA-equipped database from 2015, 3.2% of bypass patients underwent a concurrent laparoscopic cholecystectomy. Using propensity-matched analysis and multivariate logistic regression using concomitant lap chole as a predictor, they found that the bypass with the lap chole group had an increased OR time by 28 minutes, of course not surprising. No difference in major complications, no difference in mortality, an increased length of stay by 5 hours, which isn't clinically significant. And they concluded that lap chole is safe when indicated for gallstone disease. Moving right along to NAFLD and NASH. To review quickly the histology: normal healthy liver tissue. NAFLD, there's accumulation of fatty acids and triglycerides. In NASH, there's inflammation seen histologically. High-risk NASH is NAFLD, NASH plus fibrosis. And this can, of course, go on to cirrhosis with portal hypertension, decompensation, and hepatocellular carcinoma. NASH and fibrosis is the second leading cause of liver transplantation. It's the leading cause in women. There's no FDA-approved pharmacologic therapy to reverse the disease, but there is a major focus currently on drug development efforts. And these are some of the targets that are currently in phase 2 and phase 3 clinical trials. So there will be specific medical treatments coming soon. And I think that implores us to diagnose this condition more frequently by doing liver biopsies. Liver fibrosis is the most important feature. Predicting outcomes, there was a huge international longitudinal study done retrospectively over 1975 to 2005. They analyzed 619 patients who were diagnosed with NAFLD. They were untreated, consecutively biopsied, and the median follow-up was over 12 years. In that time, 193 patients, or 33%, either died or had liver transplantation. And they found that histologically only fibrosis stage was associated with poor outcomes of mortality, liver transplant, and other liver events, and no other histologic features were. We looked at this in the NIH-funded lab study, which I was a part of. We evaluated liver biopsies done as what was considered standard of care at that time. There was a variation on what surgeons consider standard of care. In the 38 participating surgeons, 3 of them biopsied over 80% of patients, 8 biopsied between 20 and 80%, 20 biopsied less than 20%, and I was in that group, and 7 did no biopsies. The strength of this study was that we had a single experienced liver pathologist evaluate all slides. We found that more than 40% had interface hepatitis, otherwise known as piecemeal necrosis, 4.2% had bridging fibrosis or cirrhosis, 13.7% had a NAFLD activity score of 5 or greater, that's a score of 1 through 8, where 5 or greater is bad, 16% had steatohepatitis, 17% had borderline steatohepatitis. There was a study published last year in SWORD out of Harvard, and their objective was to assess routine liver biopsies and the prevalence and risk factors for NASH and fibrosis. So they did wedge liver biopsies in 2,557 patients between 2001 and 2017. This accounted for 97.7% of their primary bariatric procedures. They reviewed the path reports and they staged fibrosis by the Brunt criteria. They found that 61% had steatosis, 31% NASH, 29% fibrosis, 7.8% a significant fibrosis grade. And the risk factors for these liver problems were AST, ALT, hemoglobin A1C, and specifically in the diabetes range with over 6.5%, had an odds ratio of greater than 3, which is huge. And so they concluded that there's a high prevalence of NASH and fibrosis in patients having bariatric surgery for obesity. The risk factors are AST, ALT, and hemoglobin A1C, and possibly many more patients could benefit from biopsy as therapies become more robust. There was a meta-analysis done out of Hamilton, Ontario, Canada. Senior author Dennis Hong, one of my old fellows. They looked at studies that looked at bariatric surgery effect on NAFLD and studies that included biopsies before and after bariatric surgery. 32 studies were included with over 3,000 biopsy specimens. And they found, very interestingly, that there was resolution of NAFLD after bariatric surgery. Steatosis in 66%, inflammation in 50%, ballooning degeneration in 76%, and fibrosis in 40%. So bariatric surgery is currently the best treatment we have for NAFLD. However, they did also find that there was new or worsening NAFLD after bariatric surgery, including fibrosis in 12% of patients. So, of course, more study is needed. So in summary, simultaneous surgery, hiatal hernias, cholecystectomies are safe. There's an increased risk with doing ventral hernias concurrently. There's a significant diagnostic benefit in doing liver biopsies. What do? Hiatal hernias frequently, ventral hernias rarely, lap choles rarely, liver biopsies uncommon. So as you reflect after this meeting, you're going to make any changes? Maybe more hiatal hernias, maybe more less ventral hernias. I would advocate for more liver biopsies. Thank you very much for your attention.